نستارت على طول. دكتور يلا بسم الله. السلام عليكم. إن شاء الله in the next few minutes I'll talk about some practical tips and pitfalls directed mainly for younger generation of radiologists. Some ER cases, mainly radiology resident, will face. Starting with the first case. Young girl presenting with mild pain and some recently noted urinary frequency. ER physician suspecting cystitis. From the first look, what is this? Yes, this is the mistake I want to hear. Urinary bladder. It looks like urinary bladder. This is LS and this is TS. Good. Let's revise some basic morphology. Urinary bladder in TS view should be rectangular, not circular. Urinary bladder in urinary bladder in LS view should overlie the cervix and vagina, inferior or behind symphysis pubis, the shadowing structure. But here it overlies the cervix. This is at a higher location. What should I do? Just angulate the transducer inferiorly to reach behind symphysis pubis. This is the urinary bladder. And this is simple ovarian cyst. Yes. It's a common mistake we face in early residency. Okay. The next step. What about this ovarian cyst? The patient may present with some urinary frequency because of mass effect. But more important, the pain. The patient in pain. This is ovarian cyst. Is this a normal location? Ovarian cyst should be to the side of the uterus, not anterior, never to be anterior, never posterior, never superior. So what is your suspicion? Torsion. Ovarian cyst or ovary or ovarian mass in abnormal situs, suspect ovarian torsion until proved otherwise. Other case with, it's a classic hemorrhagic cyst, but the ovary in superior location. If this hemorrhagic cyst about 4 centimeter, nothing to worry, reassurance, but the location. Superior location means ovarian torsion again. Another case presented with left iliac fossa pain. I informed the clinician she has right-sided dermoid. It looks like dermoid. So maybe torsion of dermoid cyst. Right side, the clinician insisted. She has left-sided pain. So we complemented by MRI because we are suspecting torsion. Any adnexal cyst or adnexal mass accompanied by pain, suspect torsion. What about this? And what about this? I misinterpreted this hypoechoic structure as a bowel, but now in MRI, it was the right ovary. And this structure, I misinterpreted as the right ovary. It was actually the left ovary in opposite position. What about this structure? I misinterpreted as left ovarian lesion, maybe dermoid, but actually it was torsid fallopian tube. And this echogenic structure, echogenic pattern in sonography, maybe fat in dermoid, maybe posterior enhancement, maybe acute hemorrhage. Acute hemorrhage also has echogenic pattern. So this ovary in abnormal situs. The guidance here is pain. I know there is adnexal lesion, mostly dermoid, but pain raises the possibility of ovarian torsion. So please, if you are suspecting torsion, the next modality, if you are not sure, urgent MRI, okay? So lessons from this case, you have to revise the morphology, basic morphology about urinary bladder and cyst. Ovarian cyst in TS should be circular, not rectangular, okay? And urinary bladder should overlie the vagina, should be seen inferior, starting inferior and behind symphysis pubis, not above. Ovarian cyst or ovary in general should be to the side of the uterus, never anterior, never superior, and should not be posterior. Posterior may have another differential diagnosis. I'll tell you in a minute. So this was a simple ovarian cyst with torsion. Another issue here, in the Gulf area, there is limited ultrasound studies, like this case. 18 years, virgin with acute right lumbar pain, ER physician suspecting renal stone. So he requested limited study, QB ultrasound, urinary bladder and kidneys only. The mistake will come here. Kidneys are good, urinary bladder is good, and both ureteric jets are seen, so mostly no obstructing stone. But the patient has pain, right lumbar pain. Trace the adnexal. Ask about last menstrual period. She is a female. Last menstrual period 2 weeks ago. So I am suspecting corpus luteum or hemorrhagic cyst, something gynecological. Okay. What about the right adnexal? Echogenic lesion. Echogenic lesion measuring about 4 centimeter. No vascularity. Okay. The most common lesion, dermoid. So most likely dermoid. Every radiology resident will say dermoid. But what's behind this lesion? Dermoid containing fat, not, yes. Fat, echogenic. Acute blood, echogenic. But fat usually displays posterior attenuation because ultrasound is attenuated significantly in fatty tissues. So posterior attenuations means fatty structure, but here posterior enhancement. Blood act like water, nil attenuation. So ultrasound beam is enhanced behind the acute hemorrhage. So this structure, mostly acute hemorrhagic cyst in a normal location, nothing to worry about. We followed up this case. Now, classic clot retraction, alhamdulillah, okay? So we have to be aware about different patterns of hemorrhagic cyst, especially at resident level. Commonly, the hemorrhagic cyst presented with a reticular pattern. Another pattern, clot retraction. These common pattern mentioned in ORATs, but there is an uncommon pattern, like acute hemorrhage, echogenic with posterior enhancement in a normal location, okay? Another pattern, fluid layering. But the non-dependent component should be echo-free. Otherwise, I will diagnose it as endometrioma. Endometrioma is the most common adnexal lesion displaying fluid level. But mostly the non-dependent portion will show low-level echoes. Okay? So, lessons from this case, we have to revise the pattern of hemorrhagic cyst. We have to think in any female with acute pain, look for, common is common, look for corpus luteum or hemorrhagic cyst, even if the presentation is not classic. Right renal colic, right iliac fossa pain, look for gynecological causes. And you have to be aware about some physics. Echogenic structure may be fatty, maybe acute blood, maybe posterior enhancement, and so on. Correlate with clinical. Another case, 28 years old, left iliac fossa pain. ER physician, I remember surgeon, suspecting acute diverticulitis. Acute diverticulitis, acute left iliac fossa pain versus gynecologic cause. Alhamdulillah, she has IUD, so I can, yes, I'll tell you in a minute. This is a clear cyst, okay? Alhamdulillah, nothing in the left iliac fossa, but we have left cyst. What is the common appearance for this cyst or common etiology? Hemorrhagic cyst. Abdominal ultrasound alone is not enough. Because if I say this is hemorrhagic cyst, reassurance and send home. I have to complete. Don't say hemorrhagic from abdominal ultrasound only. Don't say hemorrhagic if not classical. We complemented by transvaginal, now classic endometrioma, ground glass, low-level internal echoes. Abdominal ultrasound is not enough. Vaginal ultrasound is higher in characterization of adnexal lesions. Alhamdulillah, hemorrhagic cyst, endometrioma, dermoid cyst, the classic pattern, ORADS 2. It's totally benign, especially if below 10 centimeter. Yes. Another case with the same etiology, with the same pattern. 2 cysts, low-level internal echoes, classic endometriomas. But ovaries now in abnormal location, posterior to the uterus, kissing each other. This is exception of the rule. Yes, ovary in abnormal location, but containing endometriomas, no acute pain. This is pelvic endometriosis, not just endometriomas. If endometrioma is isolated, it's okay. If endometriomas attached to each other posterior to the uterus, usually there is element of deep infiltrating endometriosis. We have to continue for dynamic transvaginal ultrasound. Another case, this is sagittal view of the uterus. Look for this ovary. Normal appearing, but in abnormal location, posterior to the uterus. And now, what about the other ovary? Posterior and inferior. It is located behind the cervix, behind torus of the uterus, along the area of uterosacral ligament. I know it's in abnormal position, but it is not torsion. This cyst, low-level echoes, endometrioma. What is your suspicion? If endometrioma is fixed, try to move it. Try to manipulate the transducer. If it is fixed, suspect deep infiltrating endometriosis. Ask for dynamic ultrasound. What is this structure? Gut signature. This is the rectum, yes, lower rectum, upper rectum. What is this structure? Endometriotic nodule, yes. If you're suspecting pelvic endometriosis or peritoneal endometriosis from the classic standard transvaginal ultrasound, you have to complement. Look for other foci of deep infiltrating endometriosis along the bowel, along the urinary bladder, along the distal ureter, and so on. So this was endometriotic nodule, and so on. So if classic endometrioma, this is usual case. If kissing endometriosis or fixed endometrioma, endometrioma in fixed posterior position to the uterus or inferior position, complement by transvaginal dynamic. Sliding of the uterus, sliding of the ovary, look for bowel and urinary bladder endometriosis. If not by yourself, it's okay. Ask for a consultant. So this case need to be referred to a higher level. Basically, transvaginal is superior in abdominal, and if you see this pattern of endometriosis, complement. Another case, 28 years old, virgin. Virgin, so I cannot perform transvaginal approach, but I can still use the probe. I'll tell you in a minute. Mild pelvic pain, menstrual irregularities. I'm looking for a gynecological cause. Yes, we should ask about dysmenorrhea, dyspareunia, especially dyspareunia. And during the examination, actually, look at vaginal wall while withdrawing the transducer. This is very important. It can solve a dilemma for the patient. The patient has thick hyperechoic endometrium. This is luteal. So I'm expecting corpus luteum, hemorrhagic cyst. So what in the right adnexa? Reticular pattern with layering. This is classic hemorrhagic cyst. But what about this compartment? This compartment lies in the near field. I have to enhance the resolution. Now, it contains echogenic focus. The other possibility will be dermoid, okay? What to do to enhance the resolution? I cannot perform a transvaginal ultrasound. I will use the transvaginal probe or transducer on the abdominal wall because it's higher frequency transducer. Now, it's a clear low level internal echoes. Dermoid versus endometrioma, okay? Short-term follow-up, hemorrhagic cyst, complete resolution, and the other cyst, varices. Now it's time for further characterization, of course, MRI. Classic T2 shading with no drop of signal in fat saturated, it's endometrioma. So this double pathology and double common pathology, hemorrhagic cyst and endometrioma. Addition of using a higher frequency transducer through the abdominal wall is very helpful. We can use the microconvex transducer used for cranial sonography. We can use even the transvaginal transducer, or if slim patient, the linear transducer. Like next case. Next case, 9 years old, presented with acute pelvic pain, sent from a pediatric clinic, suspecting mesenteric adenitis or mild form of appendicitis, but she is a female. Remember, when presented to ultrasound unit, the pain is faded away. No pain. Pain on and off. Think of intermittent, yes, but unfortunately, I couldn't see both ovaries by abdominal approach. No problem. Transvaginal transducer on the abdominal wall. You see, it's, by the way, microconvex. Small right-sided ovary, this is normal for age, and the left is enlarged. Enlargement. Ovarian edema is the most important single sign in ovarian torsion. If doesn't contain any mass or cyst, but if it contains mass or cyst, abnormal location. Doppler, no vascularity, provided that low setting, BRF below 10 centimeter per second, high color gain, high wall filter, okay? Low wall filter. But if I see vascularity, it will not change the diagnosis. The diagnosis is based on B mode finding, enlarged ovary by comparison, stromal heterogeneity, and there is good sign in this case. Yes, follicular ring sign. Echogenic, thickened echogenic wall of the follicles. This is early sign. It's a good sign. I told the clinician it's ovarian torsion. He didn't believe me. I told my colleagues in radiology, ovarian torsion. Didn't believe me. No pain. So we complemented MRI for confirmation and documentation. Transverse orientation of the right ovary, small size. Vertical orientation of the left ovary, stromal edema, and it's confirmed and alhamdulillah saved. Operation done within less than 2 hours. Okay, so lessons from this case: inversion, or in children, or in female with refusing a transvaginal approach, have pelvic inflammation, pain, and tenderness. Use the transvaginal transducer through the abdominal wall. Use the linear, use the microconvex, any higher frequency transducer, okay? Endometrioma. The next case presented with folliculometry, follicle monitoring study. Under fertility treatment, the right ovary is fine, responding well, and the left ovary shows classic endometrium. Sorry, dermoid, okay. Classic dermoid. And this is by abdominal approach. This is easy case. What I need here to measure the dermoid, if it is less than 9 or 10 centimeter, because it belongs to a category, and above another ORADS category by ultrasound. Another case with the same etiology. This is the left ovary. I cannot see the right ovary. Patient has chronic pelvic pain, but mild, no fever. I cannot see the right ovary, but do you see this increased echogenicity in the pelvis? This increased echogenicity, maybe echogenic fat, BID, or maybe something else. Is it localized now? Another dermoid with fluid leveling. Okay, the measurement now about 6 or 5 centimeter. Oh, that's 2. But now it's elongated, bilocular. Now the size more than 11 or 12, another category. So get the maximum length of this lesion to put it in the appropriate ORADS category. It's bilocular with fluid level, and of course the classic MR criteria with drop of signal in fatty tissue. So this is a dermoid cyst incidentally found during fertility treatment or folliculometry. You have to be aware about the different patterns of dermoid cyst. Dermoid cyst is a great mimicker. It has many patterns, some classic, some is not, like this case. Middle-aged female, mild right loin pain. Again, requesting KUB study. In the Gulf, most of these studies done by technician sonography, not by physician. But I insist to revise every case because look for a cause of the pain. No, ignorable. Yes, but ignorable. I'm looking for a cause of pain, not just cystitis. Urinary system looks fine, kidney fine, urinary bladder fine. Should look for adnexa. Left ovary is well seen. I cannot see the right ovary. Anything in the pelvis, this echogenic structure may be bowel, maybe dermoid. If you are not sure, ask the patient to go to the bathroom, to walk for 1 minute, and see if this pattern is fixed or mobile, it changed, or something else. The left, I cannot see the right, and here is the uterus. Not classic. This is not classic, but I'm suspecting there is something here. What to do else? Doppler. Why? I don't I know there is no vascularity in dermoid, but dermoid will have mass effect. You see the vessels here around, it is compressed, it's displaced the vessels. This vascular compression suggesting there is something here. If you are suspecting, re-examine or send for another superior imaging modality. Yes, MRI. It was a classic dermoid. So remember, dermoid is a great mimicker. May have similar appearance to bowel gases and food residue. If you get this suspicion, please complement. Either follow up short term or MRI. Use the color Doppler to guide you. Look for mass effect. So this case is a dermoid cyst. Okay. Another case. I'm looking for the time. Yes. 9 years old, presented from urology clinic. Because she has problem with urination. Please, Mr. Radiologist, measure the urinary bladder before and after voiding. Okay. What else? Incidental finding. The adnexa contain, the left adnexa, cyst, maybe functional, 9 years old. It's okay. But LS, is it simple cyst or? Yes. First, this is the ovary. This is the ovary. And this is elongated tubular structure. Hydrosalpinx in this age, maybe look for the other adnexa, please. No, the uterus is fine. Uterus is fine. Here is the uterus. It's okay. And this is the left side. Sorry. This is the right side. Bilateral hydrosalpinx in children? Yes. What is the etiology behind this? Ask about previous operation. The commonest source for occlusion is adhesions. No endometriosis in this age, okay? Dual, left and right, yes, yes. So it has, she has bilateral hydrosalpinx, 9 years old. This is called pediatric hydrosalpinx, uncommonly seen, but usually after abdominal surgeries like appendectomy, and may have spontaneous resolution, okay? So this is hydrosalpinx in young age. The trick here is elongated pattern, tubular structure, especially on the left. On the right, you may think of mucocele of appendix, okay? But usually you need another imaging modality, like MRI. Okay, difficult case. It's abdominal, not gynecological. Just a minute. Middle age, yes, middle age patient, 2 or 3 weeks postpartum, has epigastric pain and concurrent pelvic pain, vomiting, high TLC. I'm looking for postpartum infection or inflammation. Okay, I'm a radiologist. I started with the right hypochondrium. What's here? Yes, but acute calcular cholecystitis is very good possibility from this appearance, but your gallbladder wall is thickened, not hyperemic. Urinary bladder, gallbladder average extension, not over-distended. Stones are mobile, not impacted in the neck. Still, acute calcular cholecystitis is a possibility, but try to analyze the pelvic pain. Pelvic pain, there is some content, increased echogenicity in the fat, significant increased echogenicity in the fat, and yes, what is this? Left adnexal, elongated structure, hydrosalpinx. Maybe pyosalpinx, yes. To be sure, I cannot see this area, no problem. Use linear or transvaginal, incomplete septi is seen. Okay, how to gather all findings together? Pelvic inflammation, hydro or biosalpinx, and cholecystitis. Any pathology gather all together? Fitz-hugh-curtis syndrome or perihepatitis. Inflammation, because the patient has repeated attacks of BID, so this is most likely a chronic hydrosalpinx and activated now spread of infection along the right paracolic gutter. This is another case also from practice, pelvic inflammation and subhepatic echogenic fat, turbid fluid, it's perihepatitis again. Yes, yes, around the liver, gallbladder wall thickening, increased fat echogenicity, along the liver, below the liver, along the colon, along the right paracolic gutter. This is a source of ascending infection from the pelvis to the right side of the abdomen. So correlate between right hypochondrial pathology and pelvic pathology. This is Fitz-hugh-curtis syndrome. Okay, another case, 21 years old, right iliac fossa pain. The pain is repeated many times. The clinician usually thinking of repeated mild attacks of appendicitis or mesenteric adenitis. Right iliac fossa looks fine, so check the adnexa, please. What about the right adnexa? Is this pathology? Maybe dermoid? Yes or no? I don't suggest dermoid because I see the ovary itself. It's not, yes, it's extra ovarian. Yes. What about this structure? Maybe thickened tube, yes. Other adnexa, what about this tubular structure? Hydrosalpinx, very good. I'm happy to hear this mistake. Okay. Maybe, but just a minute. Doppler will solve this case. What about the right ovary? Hybremic. What about the and the edematous? What about the fallopian tube? Thickened and hybremic. What about this echogenic structure? It's echogenic fat. Hybremic fat with edema. Echogenic fat is your best friend in localizing acute inflammation or acute edema or even around torsion. So this side, acute salpingitis. What about the other side? Is this fallopian tube? I'm putting Doppler no color. Simply, just a minute. What is the differential diagnosis of dilated tubular structure? Pelvic varices. But pelvic varices has very slow flow. Ask the patient to Valsalva. Now it's pelvic varices. So the patient has two sources of chronic pelvic pain, dysmenorrhea, dyspareunia, and. BID activated on the right side and pelvic congestion on the left side. This case in need for ovarian vein duplex study because it's commonly secondary to ovarian vein incompetence. So we have two mimics here. This is not dermoid, this is salpingitis, and this is not hydrosalpinx, this is, yes, pelvic varices. Thank you. Any questions? No? Alhamdulillah. Okay, okay.
Thank you very much. Thank you very much, Professor Ismail. Now, there is any question for the speakers? We'll start by Professor Tania. There is anyone want to ask Professor Tania in the 4 talks? Yes, Doctor. Okay.